Male pelvic training dates back to ancient Greece and Rome, where it was performed in the baths and gymnasiums. Strengthening these muscles was thought to promote general and sexual health, spirituality, and longevity. In the 1940s, Kegel popularized exercises of the female pelvic muscles to improve urinary and sexual health after childbirth. Men have virtually the same pelvic floor muscles as do women, and an equivalent capacity for exercising them, with parallel benefits to urinary and sexual health. My objective is to review the benefits of pelvic floor muscle training in males and to help popularize it for males, as Kegel did for females. Our medical ethos is pharmacology and surgery-centric, with aggressive prescription writing by physicians and a patient population that demands a quick fix. Unfortunately, our medical culture does not in general promote lifestyle improvement and exercise programs. The time has come to prioritize the promotion of health over the eradication of disease. Because of its simplicity, safety, non-invasiveness, and its potential for empowering men, pelvic floor muscle training should be used as a first-line approach. Less invasive strategies should always be considered before more invasive approaches that are more costly and have greater side effects. Pelvic floor fitness is critical to healthy pelvic functioning, and pelvic muscle training serves a role in many pelvic conditions that require multimodal approaches. Pelvic muscle training is by no means a magic bullet, but is beneficial in the prevention and treatment strategies for a variety of pelvic issues. In terms of its efficacy, pelvic training may not always be a home run, but certainly is a base hit. It is common knowledge that pelvic muscle training can aid stress incontinence and inhibit involuntary bladder contractions. However, in addition to benefiting continence problems, it can also improve erectile and ejaculation issues. It is useful in the male urology patient with stress urinary incontinence, overactive bladder, post-void dribbling, but also erectile dysfunction, ejaculatory dysfunction including premature ejaculation, and pelvic floor tension myalgia. The deep pelvic muscles, the pubococcygeus, iliococcygeus, and puborectalis muscles, in conjunction with the urethral and anal sphincters, are vital for urinary and bowel continence. The superficial pelvic muscles, the bulbocavernosus, ischiocavernosus, and transverse perineal muscles, function in maintaining erectile rigidity and the expulsion of urethral contents. The bulbocavernosus engorges the glands and corpus spongiosum, expels residual urine from the bulbar urethra, and ejaculates semen. The ischiocavernosus stabilizes the erect penis and inhibits venous return to help maintain penile rigidity and corporal cavernosal blood pressures that far exceed systemic blood pressures. As with all skeletal muscles, the pelvic muscles are subject to adaptation. Applied exercise can enhance their strength, tone, and endurance. Pelvic floor muscle training can be beneficial not only in treating the aforementioned conditions, but also as a means of helping to prevent them. For example, pelvic muscle training before undergoing prostatectomy can help avert the occurrence of post-prostatectomy stress incontinence. This holds true for every domain in which pelvic training has utility. Pelvic muscle training is the essence of functional fitness, training muscles to help in practical life activities. Pelvic muscle training in males remains under-recognized and underutilized, despite evidence of efficacy. These muscles are crucial to male genital urinary health, and there is every reason why male pelvic floor exercises should achieve the same recognition, use, status, and traction as in females. Demand for the management of pelvic floor disorders is increasing, and there is a major growth opportunity for office-based specialized urology services that provide and teach behavioral treatments such as pelvic training. In current urological practice, patients typically receive pelvic muscle education by verbal instructions or a pamphlet, and occasionally via in-office biofeedback or referral to a physiotherapist. There exists an unmet need for an effective means by which a comprehensive pelvic training program can be made easily accessible and available